cyanosis. So definitely cyanosis, as we all know, is the bluish discoloration of skin and mucous membranes due to increase in deoxy hemoglobin levels. Desaturated arterial blood gives us what we call central cyanosis, and this is what we are going to talk about today in congenital heart disease. Peripheral cyanosis, uh, peripheral cyanosis. ايش الخطوط اللي بتطلع على غريبة. Peripheral cyanosis usually is with normal arterial saturation. This is important to recognize that when you see cyanosis, you have to have a pulse oximeter reading. Well, today we cannot accept any vital signs for any child who's coming to your clinic without a pulse oximeter, because we can miss cyanosis easily. We also want to differentiate between central and peripheral. The only way to do is to get a pulse oximeter or a blood gas. So blood gas is not something practical to do in every patient. Only in patients, outpatient will be difficult. Clinically, our eyes can see only cyanosis if the central saturation is 85% or less. طبعا if this is how it is, then for sure we are going to miss so many cyanotic CHDs, because there is quite a bit of group of cyanotic heart diseases where the saturation is actually 88 to 94. These ones with increased pulmonary blood flow, even though they are cyanotic, but they have increased pulmonary blood flow, these will be missed. So that just tells us again that we have to have a pulse oximeter on every baby or child coming to your clinic to be able to detect any low saturation that the eye cannot detect. Central cyanosis causes, for sure, it's either respiratory, CNS, muscular, myopathies, CNS apneas, respiratory, whether it's infection or apneas, and cardiac for sure. And this is our interest today. Peripheral cyanosis can be seen in cases where we have sluggish circulation, poor peripheral perfusion, like in CHF, shock state, and normal acrocyanosis we see in babies who are born when they, especially after they get a bath. You can see that their hands and feet become bluish. And also you have to, if you get cyanosis, you have to really pay attention to abnormal hemoglobin. Methemoglobinemia is there, and it's possible to diagnose. And we have to be careful when we get a cyanotic child not to miss such an abnormality. طيب. Types of cyanotic congenital heart disease, if you divide them, there are so many ways of dividing congenital heart disease, cyanotic type. One of the good ways to divide is dividing them compared to increased or decreased pulmonary blood flow. So we group them into either the group with increased pulmonary blood flow or the group with decreased pulmonary blood flow. Good examples of increased pulmonary blood flow is detransposition or dextrotransposition of the great arteries, Truncus Arteriosus, total anomalous pulmonary venous drainage, double outlet right ventricle, and single ventricle with no pulmonary stenosis. Good examples of decreased pulmonary blood flow, cyanotic congenital heart disease, tetralogy of Fallot, critical pulmonary stenosis, not any pulmonary stenosis, critical pulmonary stenosis, and pulmonary atresia, or the above in association with significant pulmonary stenosis, like if you have single ventricle with severe PS, then it will go into this type that we are seeing. Just give me 1 second, please. طيب, we are back. So let's take it now one by one. This is transposition of the great arteries. This is the cartoon of a normal heart. You can see the right atrium to right ventricle to pulmonary artery connection, then the pulmonary veins to left atrium, mitral valve, LV, and aorta, normally causing normal circulation. This is a cartoon heart of the baby with transposition of the great arteries. You can see the RA to RV connection normal, so AV concordance, and you can see the ventricular arterial connection, which is abnormal, which is RV to aorta, so VA discordance. Same goes for the left side, LV to pulmonary artery, before that LA to LV, LV to pulmonary artery. So we can see right away here that what we have is that the venous blood or the systemic venous blood is coming from the body to the right ventricle back to the aorta, and it goes to the body and comes back to the right atrium, to the RV, aorta, body, and so on. And you can see that also the left atrial blood, which is coming from the lungs, is going to the LV, to the lungs, coming back to the atrium, to the LV, to the lungs again, what we call circulation in parallel. What we call is circulation in parallel, not circulation in succession. The normal circulation has to be in succession. I like to always give the example عن سباق 400 متر تتابع. Everyone gives the other the baton, and that's why the team succeeds. In transposition, there's no 400 متر تتابع. The blood just goes in parallel, so they don't work with each other and they end up with severe cyanosis. You can see in this cartoon that the presence of a communication between the left side and the right side, here it is the ASD. The presence of such communication is so important for the patient being able to live. Otherwise, the patient will be severely cyanotic, hypoxic, acidotic, and die. And this interatrial communication provides what we call the mixing site. They have to mix, and since they are mixing, enough blood, enough oxygenated blood is going to go to the systemic circulation and give life to the baby. Let's go over it one by one. So as we said, parallel circulation, not in series. Go over it again. It's venous blood coming from the body to the right atrium, to the RV, to the aorta, to the body, and back. So one parallel circulation that just goes on and on. The lungs give the blood to the left atrium, to the left ventricle, to the pulmonary arteries, and back to the lung. Just give me a second, please.
بروف احنا كده اول 10 دقائق.
ممتاز. So in parallel circulation, you can see now the lungs going to the left atrium, to the left ventricle, to the pulmonary artery, and back to the lung. So the main issue here in cyanosis, in transposition, is poor mixing. And the answer to treat a patient with DTGA is to provide good mixing, the first answer before surgery, before anything. And the resultant of this poor mixing is severe hypoxemia, acid and acidemia. The baby will hyperventilate, and there will be increased pulmonary blood flow. Patient has congestive heart failure and myocardial depression. These are the main features of, or main pathophysiological features of the transposition. In parallel circulation, poor mixing, leading to hypoxia and acidemia. Patient will be hyperventilating. There is increased pulmonary blood flow. Why? Usually there is the intercostal and the bronchial arterial blood coming from the aorta to the lungs will not go back to the aorta, will just be trapped in the lung. And that's why they will have increased flow. And that gives them congestive heart failure if you leave them. Plus, another factor that can give them congestive heart failure is because of all of the above, the myocardium is now hypoxemic, ischemic, and will lead to myocardial depression. And that's why if we want to break this parallel circulation, you can see here on your right-hand side of the screen, body RA, RV, aorta body, LA, LV, PA, lungs, and so on. If we want to, and this is the normal circulation here on the left, if we want, we have to provide a communication for causing good mixing. RA to, LA to RA, and so and back forth. So a septostomy, or if the patient has a good ASD, not a small ASD, 2 to 3 millimeter PFO, or ASD would not be enough. Usually these patients will need at least a 5 to 7 millimeter ASD to survive. Or a VSD, usually the VSD is not a good mixing site. So if you diagnose somebody with DTGA and they have their usual perimembranous or high muscular or subarterial type small VSD, usually we find in them a 3 to 4 millimeter VSD. This is not enough to give them good mixing. If that's the only site, then the patient needs a site. He cannot go home. He will die with this small VSD. And definitely the PDA. PDA to remain open, we need to start the patient on prostaglandin. And usually in most of the cases, it will be quite enough to open the PDA with prostaglandin. So one could put a question here and says, okay, so I cannot do the septostomy. I'm in a remote area. I can start prostaglandin. That's good. But even if I start prostaglandin, I may not get the surgery done for such a patient. So long time ago, when we couldn't, when we did not have actually prostine or prostaglandin, we used to go for septostomy immediately for those patients, especially the ones where we cannot get surgery as soon as possible. You can do the same. If you diagnose somebody with TGA and you know that you cannot maintain prostine for a long time, or you're not going to get surgery within the first week or two of life, then a septostomy is a good way to go. The only drawback to a septostomy, if you delay the surgery for more than 6 weeks to 8 weeks, then you probably cannot do the arterial switch, and you will have to do the Senning or mustard. Or retrain the RV. It's not part of our talk today, but our main talk today is about how to alleviate DTGA cyanosis is by providing good mixing site. Again, just to show you in the same way, this is a patient with, this cartoon here is a patient with transposition. You see RA to RV to aorta. This is pre-septostomy. You can see how the aorta saturation is 45, the pulmonary artery is 92. After the septostomy is done, a larger ASD, the aorta now is 80. So a livable saturation, unlike before where it is not livable. In all ways, the pulmonary blood flow is increased. Again, for many reasons, and one of the reasons is that it's receiving those intercostals and bronchial arteries, and because the resistance falls quickly in the pulmonary artery as we go on, and there is more pulmonary blood flow. This is just a quick cartoon of the septostomy. This is the Rashkin catheter from the from the inferior vena cava to RA across the small PFO. The balloon is up. The jerk pull is done and pulled all the way down and out, and then you get your septostomy. Going now from TGA to Truncus Arteriosus, another type of increased pulmonary blood flow, cyanotic heart disease. But here, the major difference between TGA and Truncus, although they all share the common part, which is increased pulmonary blood flow, is that all the blood coming from the LV and the RV has to go through the VSD, through the aortic valve, and then to the pulmonary artery and the aorta. So what do we call this? We call this excellent mixing. And that's why you never see, you almost always never see, there are some cases for sure where you may have issues, you never see Truncus Arteriosus with significant cyanosis. They usually come to us with a good saturation of 92, 94, 88, and heart failure, obviously. Why is it heart failure? Because the aorta or the pulmonary arteries are connected to the aorta, and they will receive systolic and diastolic flow from it. Because they have low PVR, the flow will prefer to go to the lungs. These patients will have increased pulmonary blood flow, good saturations to start with before they develop severe pulmonary edema, and obviously heart failure type patient. Single ventricle is almost the same as Truncus in a different way. The good mixing, always when we talk about cyanosis, keep the word mixing in your mind and decide where is the mixing and is it good or is it bad, and that will determine the saturation of the patient, whether the patient has heart failure or does not. So in a single ventricle patient, this is just an example. There are so many types of single ventricle. This is just an example of it. Let's say this is a double inlet LV. If there is no pulmonary stenosis and there is complete mixing, as we can see in this ventricle, we expect to have a good saturation. Pathophysiologically, we expect to have a good. Good here means a high saturation. And because there is no limitation to the pulmonary blood flow, it will be significantly high in the range of 88 to 94, below 95 and above for sure 82. You will get this kind of saturation. This baby, if you leave him, will go into heart failure type cyanotic congenital heart disease because of the increased pulmonary blood flow, and will develop later on pulmonary hypertension if this pulmonary blood flow is not well controlled. Truncus arteriosus, as we said, I mean, I always talk on the picture and write it down so we all grab it quite well. There is complete mixing.
10 minutes.
تمام. احنا we have total time لي انا كم؟
الوقت اللي حضرتك تحبه.
طيب ماشي الحال. I will not take time عشان برضو الناس ما تزهقش على قولكم.
تمام.
Complete mixing in Truncus arteriosus, we have complete mixing. So what is the result of that? Minimal cyanosis. This means that these patients can be missed on physical exam if you are only looking for cyanosis. If you're looking for murmurs, they will have no murmurs. The only probably more significant sign in these patients that they will be tachypnic and they will have an active right ventricular or right ventricular heave, quite active, whether parasternally or in the epigastric area. It's important to examine in all newborns the epigastric area. If it is active, even if your cardiac exam is totally normal and nothing else is abnormal, even the saturation is normal, don't discharge that patient and get an echocardiogram. It's either pulmonary hypertension or cyanotic heart disease involving the right ventricle in a way or another. So in Truncus arteriosus, there is always almost always a VSD. There are truncuses without a VSD, and they are in deep trouble. They have identical pressure in both ventricles because the VSD is usually large and it equalizes the pressure. So obviously they are prone again to significant pulmonary hypertension very soon in the course of their disease. Single ventricle patient, Truncus Arteriosus, these patients with unlimited pulmonary blood flow and exposed to high pressure because either it's coming from the ventricle, the pulmonary artery, which has high pressure, or the aorta, both can have accelerated pulmonary hypertension, and they may reach age 9 months and even 11 months sometimes and get early Eisenmenger and become inoperable. That's why these patients are to be operated early. Truncus arteriosus no later than age 2 months, preferably between age 2 weeks to 6 weeks. Single ventricle, you have to get the pulmonary artery band very soon within the first 2 months again before these patients have trouble. Systemic circulation is proportional to the pulmonary blood flow. More pulmonary blood flow, higher saturation. Pulmonary venous resistance and pulmonary arteries caliber will determine the pulmonary blood flow. You know that not all babies born will have their PVR fall in the normal way to 1/5 of what it was by 1 week, and later on by 6 months it's back to totally normal. Some babies will actually have their PVR remaining high at birth and even after. And these patients, even if they have truncus, they will have a lower saturation and they will not be in heart failure. This is not a good sign, by the way. It's good for the patient because the patient will grow, will feed well, will not have heart failure, will not have terrible saturation. هيكون الساتوريشن تقريبا like 80 or 82, but this is not good. This is the bad sign because these are the patients, if you leave, then they will develop pulmonary hypertension accelerated quite fast. Likewise, if you have good size, large pulmonary arteries, there will be more flow. If they have peripheral pulmonary stenosis in association with truncus, with any other disease, cyanotic, with increased flow, this will limit the flow. And again, these patients are not going to be in heart failure, but they are poor outcome because their pulmonary arteries are small. It may render them inoperable, or we have to do something about these pulmonary arteries to make them grow, either by adding shunts or surgically by enlarging those pulmonary arteries. Congestive heart failure is the usual presentation of such pathophysiology. Eisenmenger syndrome may develop very fast in these patients, as I said. Aortic stenosis, aortic regurg are complicating factors. So here in truncus especially, it's not just the pathophysiology of the cyanotic heart disease, but there is an additional pathophysiology, which is the truncal valve. It can be severely stenotic. It can be severely regurgitant with a lot of insufficiency. So if this happens, then you will add that pathophysiology to it. If there is severe aortic stenosis, these patients will have low cardiac output state, low perfusion, and low saturation, because all depends through here. If they have severe aortic regurg, they will show some myocardial dysfunction because of coronary artery steal phenomena. The aortic regurg would take the blood away from the coronaries. Plus, the pulmonary arteries are taking the blood away from the aorta, which leaves the ascending aorta with low cardiac output. It is stolen by the pulmonary arteries and stolen by the aortic regurg. So you can have myocardial dysfunction significant in these patients. Plus, it may render these patients inoperable if it was severe aortic regurgitation or severe aortic stenosis. Total anomalous pulmonary venous drainage is another example. We are talking about the non-obstructed type. A good example, usually not obstructed, is the supra-diaphragmatic type. Here, you can see this is the normal heart again. You can see here the left atrium is not receiving any pulmonary vein. Where are the pulmonary veins going? In this case, they are connecting to the SVC. Most of the time, they are actually connecting to the innominate vein somewhere in this area. So let's go again, and we learned how to decide about mixing and not mixing, and we learned how mixing is one important concept in congenital heart disease. So let's see how is this patient going to mix. Obviously, the pulmonary venous blood flow is going to come to the SVC, and all the venous flow, SVC, IVC, and pulmonary vein will be mixed here in the right atrium. So if they all mix in a good one large chamber, are they good mixers or poor mixers? Obviously, they are good mixers. So do we expect total anomalous to be low saturation or higher saturation to be higher saturation? Obviously, if you are total anomalous, then how is your left side going to get blood? There will have to be what we call a mandatory ASD in this diagnosis. So a right to left shunt will go and feed the left atrium and the left ventricle and maintain the cardiac output. They are dependent on this ASD for their cardiac output. If the ASD is a small PFO, then they may show signs of low cardiac output. They will look gray, acidotic, again, because of low cardiac output from the left side. But this is not the usual. The usual is they are high saturation, congestive heart failure type patient, increased pulmonary blood flow, again, because the blood now have two sides to go to, either to the left side or to the right side. The RV compliance as the baby goes on in age, the first few days, the first few weeks, becomes better. The pulmonary artery vascular resistance drops, so the blood will actually prefer to go here. So we'll have increased pulmonary blood flow, pulmonary edema, and high saturation. Total anomalous pulmonary venous return infradiaphragmatic type, they are usually obstructed. So let's talk about them as if they are not obstructed. Will they be any different from the supracardiac? No, they will not be different, because again, all the blood will mix here. The ASD takes it to the left side to maintain the cardiac output, and the right ventricle would take the more blood and they will have high saturation. But unfortunately, this is not the usual. Infradiaphragmatic are usually obstructed. So although they are good mixers, they will still present to you with severe cyanosis, severe desaturation. Do you know why? It is because of two pathophysiological mechanisms going on. Because of the obstruction lower down here, they will have what we call pulmonary venous edema. Pulmonary venous edema. The pulmonary veins will be high pressure. Once they are high pressure, the basement membrane of such veins and venules will dilate, and the pores, the normal pores in the basement membrane will get larger, and then the intravascular fluid will leak to the extravascular compartment in the lungs, causing pulmonary interstitial or venous edema. That will prevent good oxygenation, so these patients will have severe desaturation, plus it will make the pulmonary artery and resistance very high, adding to limiting the pulmonary blood flow and the severe desaturation with severe cyanosis. These patients, the obstructed ones, are a top emergency. They have to be operated or this obstruction relieved immediately. Otherwise, they die within the first few hours because their lungs transform into liver-like structure. It will get severely filled with blood and congested, and this blood is unable to move from the lungs to the body because of the obstruction. In addition, they will have low cardiac output. So all these pathophysiology can happen in total anomalous with obstruction. So going back to the writing part, total anomalous pulmonary venous drainage or return, non-obstructed total anomalous, similar hemodynamics to a large ASD, a very large ASD, or possibly a common atrium. Left to right shunt magnitude is determined by the RV compliance and the ASD size. How much goes to the left, how much goes to the right. RV compliance good, pulmonary vascular resistance low, then the lungs will see more blood flow. ASD larger, then the left side will see good flow, but it's almost always that the right side will see more flow because of the good compliance and the low PVR. Right heart and pulmonary volume overload. This is obvious from the cartoon we see that the right side will be volume loaded because of this total anomalous left to right shunt going to the right side. And here, let me tell you a side talk. How can we determine which chamber dilates and gets overloaded with any shunt? It's a very simple answer. Look for the left to right shunt going to which chamber in diastole, not in systole. So let's take a VSD. If the VSD is shunting left to right, it's going from the LV to the RV to the pulmonary artery. Yet we don't see RV dilatation in VSDs. We see left atrium dilatation and LV dilatation. Why? Because in the VSD example, the left to right shunt is going to the RV during systole. It will not dilate it. The pulmonary artery receives it also during systole. It will not dilate it that much unless the VSD is huge and the pressure is also transmitted. But the increased flow to the lungs is going to go back to the left atrium and the left ventricle during diastole. And that's why they dilate. So again here, because this is a left to right shunt, yet it is going to the right atrium and the right ventricle during diastole, there will be volume overload on the right heart with dilatation. There's complete mixing at the RA level. There is minimal cyanosis due to large pulmonary blood flow and excellent or complete mixing. Both are in favor of minimal cyanosis, higher saturation. Slight pulmonary artery pressure elevation is always seen even from the start because a lot of pulmonary blood is being received in total anomalous, much more than a regular ASD. Right, total anomalous pulmonary venous return, obstructed type, as I alluded before, pulmonary venous hypertension secondary to pulmonary artery and gives secondary pulmonary artery and RV hypertension. When it's obstructed, the pulmonary vein are hypertensive. There is pulmonary venous or interstitial edema leading to pulmonary reflex pulmonary artery vasoconstriction leading to high pressure in the main PAs and the RV. Less RV and pulmonary artery volume overload. This is obvious because the blood is being congested in the lung, it's not being received. There is significant pulmonary edema in this pathophysiology. And just to tell you, why are we teaching pathophysiology? Because if we teach pathophysiology and know these items, we can direct our treatment towards treating these abnormalities, and this will give you the best outcome in your patient. So there is pulmonary venous edema, more cyanosis and respiratory distress because the lungs are really hurt. Yet they are good mixers. So even they are good mixers, but because the pulmonary venous blood is obstructed, the lungs are pulmonary edematous, there is pulmonary hypertension, they are really usually severely cyanotic and severely distressed with also low cardiac output. This is an example of total anomalous coming to the right side, and you can see how the pulmonary artery pressure, saturation is already severely elevated, 87. With the ASD taking some blood, then the systemic saturation is almost equal to the pulmonary saturation. This one is with obstruction, and you can see the pulmonary saturation is low because there is severe pulmonary edema, there is limited pulmonary blood flow. Look at how many arrows here, and look at the arrows here, very minimal. And also the cardiac output is not good because the blood received from this area is quite limited. The cardiac output is obstructed in the lungs, literally obstructed in the lungs. Type. Another example of cyanotic heart disease with increased pulmonary blood flow is tricuspid atresia. And tricuspid atresia is a variety of diseases. It's not just one disease. There is tricuspid atresia with normally great arteries, with no great arteries, with transposed great arteries, and so on. So there is a lot of difference in tricuspid atresia. But let's go over the cartoon and try to figure out what pathophysiology is going on. So the blood is received from the SVC, the IVC to the right atrium. There is almost always an obligatory enlarged patent foramen ovale or ASD to maintain the cardiac output. So you can see these patients can present with shock or low cardiac output state or severe acidosis, and they need a septostomy if their ASD is small. This is not the usual. The usual in tricuspid atresia is that the ASD is good. But keep it in mind, a patient with tricuspid atresia, cyanotic heart disease, may present in cardiogenic shock because of low cardiac output, because the PFO is restrictive or not enough. So let's ask the question, are they good mixers or poor mixers? Again, they are good mixers because all the blood from the right side is going to go all to the right atrium and all to the left ventricle. They have enough chambers to mix well in them. And that's why you can see the saturation is good, higher, not good normal, but higher. That means it's 85, 88, 92, 94, never 95, but 94 down to a range of 85. And they mix well. So now we'll have to talk. Another additional factor. There is no pulmonary stenosis. We have decided before, if you are a good mixer and you don't have pulmonary stenosis, what will you have? You will have increased pulmonary blood flow, high SAT, and then you will have congestive heart failure. This will happen in tricuspid atresia if the pulmonary blood flow is not restricted. And in tricuspid atresia, there are many ways of restriction of pulmonary blood flow. It could be at the VSD site, the subpulmonic site, or the valve itself, or the supravalve. So multiple areas. If the VSD is large, there is no subpulmonary stenosis, there is no valve pulmonary stenosis, then the pulmonary blood flow will be increased. If it is restricted, it can be restricted to cause good balance. They will not be in high SAT, no heart failure, good cardiac output, or it can be so restricted, they will be extremely limited pulmonary blood flow, and they will transform into congenital, cyanotic congenital heart disease with decreased pulmonary blood flow. So in tricuspid atresia, we can see probably all the variety from starting from increased blood flow, excellent SAT, heart failure, down to cyanotic spells and severe saturation because of limited pulmonary blood flow. But the most important thing here, they must have an ASD. They are good mixers, and what determines their continuation of a good saturation is no obstruction at the VSD or the subpulmonic or pulmonic site. And also what determines they don't go into heart failure is the same thing. So tricuspid atresia, there is increased right atrial pressure and size, for sure. And not only that, there is also dilated left atrium and left ventricle. Have you ever thought about the left side being dilated because of cyanotic heart disease? It is not the common. The common is that a cyanotic heart disease causing like a VSD or a PDA causes the left atrium, the left ventricle to dilate. But in tricuspid atresia, because the RV is usually hypoplastic, all the blood is received to the left atrium and the left ventricle, and that's why they dilate. And the increased pressure in the right side or right atrium is because all blood has to go through a PFO, so there is a delay in emptying. It's a complete mixing in the left atrium and the LV. With TGA, it has increased pulmonary blood flow more than usual and increased saturation, because then the pulmonary artery will be coming from the LV and will not be restricted to flow by the VSD or others. Actually, if this happens, then you may get even an additional pathophysiology, which is small aorta and aortic coarctation, because then if there is a restrictive VSD, the aortic flow, because it's TGA, the aortic flow will be limited, and you may get a coarctation in the face of such TGA tricuspid atresia patient. And as I said, they have variable degree of cyanosis, depending on the restriction at the VSD or the subpulmonary or the pulmonary site. This is just an example. You can see here the tricuspid atresia. You can see the ASD taking all the blood to the left atrium, left ventricle. Through the VSD, the blood goes to the pulmonary arteries, and the rest goes to the aorta. In this patient with transposition, you see, the aorta is here, it goes through a VSD, the aorta is smaller because the flow is limited, but look at the pulmonary artery, how much it will get. So these patients, transposition with tricuspid atresia, they will have severe heart failure, a lot of saturation, and through the VSD, if the VSD is good size, the aorta will be good size. The likelihood of coarctation of the aorta will not be high, but if the VSD is small, the aorta will be small, and there will be an added pathophysiological factor, which is the result of coarctation of aorta. Right. Another cyanotic heart disease with possibly limited or not limited pulmonary blood flow is Epstein anomaly. What is Epstein anomaly? Downward displacement of the tricuspid valve with atrialization of a large portion of a variable degree portion of the right ventricle, causing severe tricuspid regurg, so causing high pressure here, and if there's an ASD, a right to left shunt, and it will cause the cyanosis. Epstein does not involve only the right atrium, right ventricle, but because of how much atrialization, they may develop RVOT obstruction and even up to pulmonary atresia, and that will add to their cyanotic heart disease pathophysiology and features. So let's go quickly on Epstein anomaly. Variable degrees of cyanosis depending on the amount of right to left shunt across the ASD or the PFO. If they don't have an ASD or no PFO, they will not be cyanotic. They will have a hugely dilated right atrium because of the volume and because of the tricuspid regurgitation, with all the complications of that whether it's pathophysiology of arrhythmias, pathophysiology of thrombosis, and so on. They will have an atrialized, as I said, they will have incompetent tricuspid valve, variable degree. Usually it is moderate or severe. Atrialized and small, poorly functioning RV. So basically, they mainly have a left ventricle and not much of a right ventricle if they were the severe form. And because the RV becomes small and atrialized, and because of the abnormal tricuspid valve insertion, you may develop right ventricular outflow obstruction. Pulmonary stenosis are occasionally associated. And there is another complicating pathophysiological factor is the association with Wolff-Parkinson-White syndrome, causing supraventricular tachycardia that can be associated. Sometimes you hear this over the phone. A pediatrician calls you from a far area. I have a 4-month-old who's cyanotic, not in heart failure, but with a heart rate of 220. This is very, very likely to be Epstein. Likewise, when you hear from your remote pediatrician on the phone saying, I have a baby boy who's blue, who is big, that means around 4 kilos, and cyanotic, then you will, on the phone, diagnose transposition of the great arteries, because that's how the pathophysiology dictates, and that's how you will know it. And see, knowing the pathophysiology, knowing how the disease behave, you can actually reach a good diagnosis without the need of much instruments to do so. Right. So we've talked about increased blood flow and all or almost all the types that come to mind in such patients. Now I will go to the ones with decreased pulmonary blood flow. أحمد في أسئلة في شيء أو أكمل؟
لحد دلوقتي ما فيش أسئلة، ممكن نخليها في الآخر لو حضرتك تحب.
تمام. طيب فتترولوجي اوف فلو، طب هذه علامة كويسة إنه ما في أسئلة، ولا يعني كله فاهم ولا كله طفش؟
لا كله فاهم إن شاء الله. ما شاء الله روعة ما شاء الله.
هذه ما أشك فيها، بس أخشى إنه يكونوا طفشوا.
لا الكل موجود ما شاء الله، ومتهيألي فاهمين إن شاء الله.
طيب ماشي الحال.
الله ما شاء الله. تسلمي حضرتك، موضوع
طيب
معقد حضرتك مجمعه ما شاء الله.
الله يجعل فيه بركة والخير إن شاء الله. طيب now we'll go to cyanotic heart diseases with decreased pulmonary blood flow. We have agreed before that cyanotic heart disease, the main cause of cyanosis is the degree of mixing. If you are an excellent mixer, or let me rephrase my words, to develop cyanosis, you have to have mixing of blue blood with red blood, deoxygenated with oxygenated blood. ما فيش في الكاردياك without mixing you cannot develop cyanosis. لأن احنا ما احنا lung ولا شيء آخر. So mixing is the main issue. بعدين يجي بعدها or comes after that is how much mixing and how much pulmonary blood flow. Very good mixing, very good blood flow, low cyanosis or minimal cyanosis, good saturation. Acceptable mixing, acceptable pulmonary blood flow, acceptable low saturation, 80 تقريبا. Poor mixing, plus minus, limited pulmonary blood flow, you will get low saturation, more cyanosis, and so on. So let's take tetralogy of Fallot. Tetralogy, alhamdulillah, is a disease that is quite understood, well known by all of us. Let's go over it again. This is the normal heart. What's happening in tetralogy? Tetralogy, there is a big malaligned VSD in the subaortic area with aortic override. So these are two factors. And then we get the RVOT obstruction plus the RV hypertrophy, making it tetralogy of Fallot. Let's talk about the tetralogy of Fallot now, hemodynamics. You see, the left ventricle will receive normal blood. It will eject through the LVOT. It has no problem. It will go to the aorta, no problem at all. The right ventricle will receive the blood from the right atrium. It will try to eject to the pulmonary artery, but it will face the obstruction. And also, the aorta is facing the RV through the VSD. So blood will like to go through the VSD to the aorta, and we have good mixing here, and blood will try to go to the pulmonary arteries. So in tetralogy of Fallot, the mixing is not an issue. So what determines a patient tetralogy of Fallot, cyanosis or saturation? What determines it is how much the pulmonary arteries are getting blood. So if this stenosis is severe, they will get less blood, and they will have limited pulmonary blood flow, and the saturation will be lower in a tetralogy. If the stenosis is not that severe, it is, let's say, moderate to severe, then a bit more blood will go to the pulmonary arteries, the saturation will be better. But is that the only source of increased pulmonary artery flow in tetralogy of Fallot? No. There are other sources of blood for the pulmonary arteries. You may have a PDA open through between the aorta and the PA, giving you a better saturation and may deceive you. And you may have aortopulmonary collaterals feeding the right, the left and the right pulmonary arteries and giving you increased pulmonary blood flow. So in tetralogy, even though they are excellent mixers, the saturation is determined by the pulmonary blood flow amount, by the stenosis, by the presence of a PDA or not, by the presence of pulmonary collaterals or not. Tetralogy of Fallot, decreased pulmonary blood flow and amount of right to left shunt will determine the degree of cyanosis. The more sub-PFs, PS, the more resistance the blood will face trying to go. So more right to left shunt, more cyanosis. And this is quite important to understand. The blood likes to go to the least resistant area. If the pulmonary artery is least resistant, then the blood will go more to the pulmonary artery. If the aorta is least resistant, then the blood will go. That's why hypotension is not a good thing for a tetralogy of Fallot patient, because it will lead to decreased pressure in the aorta and more right to left shunt. So dehydration, hypotension, high fever with dehydration, poor oral intake is not a good thing for a patient with tetralogy, because it will not give them the complication of that thing that's happening, but also more right to left shunt, because they have an obstruction here and a large VSD. Right. Pulmonary blood flow is mainly determined by the RVOT obstruction and the pulmonary stenosis. Is there such a thing called pink tetralogies? Yes, there are pink tetralogies, especially in very early in life, and rarely in the after the first 3 months of life. Why are they good saturation or pinkish? Because they have mild RVOT obstruction, balanced shunting across the VSD, not much right to left, and some left to right. So because the PS is not that bad, and they can have left to right plus right to left bidirectional shunting, so they will not be severely cyanosed. You can see tetralogies with increased flow. Have you ever seen a tetralogy in heart failure? It's extremely rare, but they can present with heart failure, and they can become the type of cyanotic heart disease with increased flow if and only if they have a very large PDA or multiple large aortopulmonary collateral arteries. Obviously, in the pathophysiology of tetralogy, they are equal pressures, so both ventricular pressures are high and both have, and the RV will be hypertrophied. This is just a quick cartoon here. You can see this is a patient of tetralogy here on the left-hand side with minimal RVOT obstruction. So the flow through the VSD is left to right, and yet there is some right to left. The saturation here is 80, and the body saturation is higher. It's not normal. 94 is not normal. It has to be 95 and above, but it's a good saturation. This is the pink tit because the sub-obstruction and the valve obstruction is not much. Here, when they develop more obstruction, the pulmonary artery becomes smaller, more right to left shunt, as you can see. So the aortic sat will drop from even down to 60s, and the pulmonary sat will also be low because of the limitation of flow and because of the right to left shunt. Right. And when we talk about tetralogy of flow, we never forget talking about the hypercyanotic spell pathophysiology. What's a hypercyanotic spell? When we say hypercyanotic, we know that they are already cyanotic patients. So they have a baseline cyanosis. They become hypercyanotic if and only if the right to left shunt is increased. How can we increase the right to left shunt? We previously just spoke about if you have more obstruction in this area, more obstruction sub-PFs, you can get more right to left shunt. So how can they develop it? Either it's fixed to start with, or it's dynamic. You see, this is a very muscular area. If we have tachycardia for any reason, then it is very hard for the blood to have space to move in during the very close systoles. It's tachycardia, systole ورا بعض. So you cannot have a good area or a good diameter to flow through. And this is what happens. Any cause of increased heart rate, pain, crying, excessive crying, that is, hunger, and so on, will lead to tachycardia. Tachycardia will increase the RVOT obstruction. You have more right to left shunt. This is one thing that can happen to a baby, and that's why when we examine or when we know we are receiving a tetralogy of fellow patient in the clinic, we don't allow the nurse or the doctor to just take the baby and put on the bed. Then he starts crying because he wants his mother and then goes into a hypercyanotic spell. No. Tetralogy of patient, the rule of thumb, examine them in the mother hand. If they cry, give them back to their mother immediately. You have to calm down their heart rate, because if you go into the vicious cycle of hypercyanotic spell, then you are really in big trouble. These patients may go very bad to the extent they need immediate surgery. So the best treatment of a hypercyanotic spell is to stop the injurious agent. If they are having any cause of increased heart rate, please calm them down. Another cause, if they have any cause of decreasing their systemic vascular resistance, so dehydration, vasodilator drugs, fever, any other cause of hyperdynamic circulation is not good for these patients, because it will drop the systemic vascular resistance. And if that's so, then the blood will go easier through the VSD to the aorta because it's lower resistance, as we said, and then the baby will be more cyanotic. And any cause of RVOT spasm, like during catheterization, or any medications that can cause that, you can increase the right to left shunt. And once this is done, what happens? The arterial oxygen pressure will become low. The CO2 will start to become high. Why? because when we have more to right to left shunt, we have less pulmonary blood flow, and then your pH drops. If your pH drops, the immediate message to the brain is to increase the work of breathing. So the baby will start to hyperventilate. If they start to hyperventilate, what happens? They will have more systemic venous return through the thoracic pump. When you breathe more, you withdraw more venous blood from the body back to the right atrium. And if you do that, then you are also increasing the right to left shunt, and then you go into the hypercyanotic spell vicious cycle. The best way to treat it is to break the cycle in this area. Keep the patient calm, well hydrated, away from anything that causes increased heart rate, decreases systemic vascular resistance, or making the RVOT go into spasm. If you cannot do that, then you may have to do that in a more pharmacological way by giving morphine sub-Q to calm down this area. You will have to, before the morphine, do the knee to chest position. So calm the patient, knee to chest position, maybe give subcutaneous morphine. And if all of that doesn't work, you'll have to go now into putting an IV line, giving fluid, and increasing the systemic vascular resistance, and so on. Right. Pulmonary atresia with VSD is another example of limited pulmonary blood flow, but again, good mixing or poor mixing? Good mixing, because the VSD, if it is large enough, it will give good mixing, and they usually have a PFO, will also mix whatever venous blood in the atria. So they are good mixers. So what will determine their cyanosis? What will determine their cyanosis is the presence or the closure of the PDA. If the PDA is open and good size, and the pulmonary vascular resistance is not high, they will definitely have good pulmonary blood flow, and they will be well saturated, not well meaning normal, meaning acceptable, anything between 88 to 94, but that will indicate, if they are in that range, it will indicate that they have increased pulmonary blood flow. Maybe the PDA is quite large, or they have an additional pulmonary blood flow supply, like in this picture on aorto pulmonary collaterals. So let's see how they will behave. Pulmonary atresia without a VSD, obviously these patients are dependent totally, again, on the ASD for their cardiac output. If the ASD is not good, they will have shock, cardiogenic shock. They may have low cardiac output state. If they have a good ASD, then this blood will be mixed completely through LA and LV, and also they will be dependent on the PDA to give them the pulmonary blood flow. But you can see here, the mixing site does not happen in the VSD. The mixing is in the LV, and the mixing and the cardiac output is dependent on the size of the ASD there. Pulmonary atresia with VSD, an extreme form of tetralogy, you can say that. Early cyanosis when the PDA closes. It is a ductal dependent lesion. It may be associated with MAPCAs, good MAPCAs, and then it becomes non-ductal dependent. Congestive heart failure with multiple aortopulmonary collaterals, which are large and not stenotic, or a large PDA, can happen. And there are balanced forms where either they are moderate size MAPCAs and no PDA, and they will have a good saturation, or the PDA is moderate size and they will be quite balanced. And when we say balance, we mean good acceptable saturation and not in heart failure. They can again be in different type of pathophysiology. If the ASD is restrictive, they will give you a low cardiac output cyanotic pathophysiology. If the ASD is good, that the mixing is good, and the PDA is large, they will give you congestive heart failure, good saturation pathophysiology. If the PDA is moderate size, they don't have much collaterals, they will give you a good saturation, and they will not be in heart failure. If the PDA is either too small or close, or the multiple collaterals are stenotic and small and not enough, they will present you with severe cyanosis. Here we have multiple factors that can be different. Pulmonary atresia without a VSD, early marked cyanosis, extremely decreased pulmonary blood flow, and not only that, the mixing is not as good as with the ones with the VSD. They are definitely ductal dependent. They may have RV sinusoids. The RV is totally obstructed. It cannot breathe even through a VSD. So what happens? Because of the high pressure here, they start to develop sinusoids that can connect to the coronary arteries. And that will add another pathophysiology. If these sinusoids are stenotic before they reach the coronary arteries, then this coronary artery ventricular circulation is dependent on the flow from the RV, the high pressure. Because if there's a stenosis here, blood cannot come from here to inside. It will only feed the coronaries in an antigrade way, in the reversed way. But if they are not stenotic, then you don't have a major problem. And that's important, quite important when we do surgery or when we do pulmonary valve perforation. You don't want to lower the RV pressure if you have coronary RV dependent circulation, coronary circulation on these sinusoids. Right. So RV sinusoids, RV decompression by TR, and the ones without VSD, we usually see severe tricuspid regurgitation, unlike the ones with a VSD, and this will add to the pathophysiology. They will get a large right atrium, and they may show right-sided failure with a big liver. ASD or PFO is mandatory, as I said, like in tricuspid atresia patients. If you don't have it, it may give them low cardiac output, and they may need a septostomy at birth for it if it is restrictive. So I'm coming to the end of my lecture. So in summary, central cyanosis is the hallmark of cyanotic congenital heart disease. And we have to establish it is central cyanosis by pulse oximetry or blood gas. Cyanosis is a serious symptom or sign. It is not normal. You may find in your clinic a patient coming in with no respiratory distress or minimal, and walking with a saturation of 94, or coming in with a saturation of 94. You may say, well, 94 is not bad. No, it's bad. It is cyanosis, and you have to treat it extremely seriously, as if you have a patient who's saturating even 70%. يعني 70 تساوي ال 94. They are all cyanotic, and they all can be serious disease. They can be sometimes ductal. Ductus ما يكون مقفل. It's still open. So you have to capture these patients early. And the best way to capture them is to do the pulse oximetry. Variable degrees of cyanosis occur due to variability in pulmonary blood flow. If you have more, you have less cyanosis. If you have less, you have more cyanosis. Pulmonary vascular resistance, if it is high, you'll have more cyanosis. If it is lower, you'll have less cyanosis. Limitation of flow through the right ventricular outflow obstruction. If it is more obstruction, then more cyanosis. Less obstruction, less cyanosis. Presence and size of shunting site, ASD, and also hemoglobin concentration. These patients need a good number of hemoglobin. They cannot be anemic. Anemia is one of their enemies because they're already desaturated. Congestive heart failure can occur in cyanotic heart disease. So it is not unheard of that you get a cyanotic heart with CHF. It's either because of increased pulmonary blood flow like in Truncus Arteriosus or total anomalous, or it could be due to depressed cardiac function like in transposition. Pulmonary arteriovenous malformation and methemoglobineas are non-cardiac causes of central cyanosis. Always remember, if the lungs look okay or sound okay by stethoscope and chest x-ray, if the heart looks okay by echocardiogram and the baby is still blue, there's another reason. Methemoglobinia is probably underdiagnosed. And pulmonary arteriovenous malformation. What do we mean? We mean by that? It's an arterial venous connection in the lung bypassing the alveolar capillary network. So it is a right to left shunt intrapulmonary, causing the baby to become cyanotic. And you will pick up those children. You will see sometimes a 3-year-old, a 6-year-old in your clinic who comes to you and the mother complains, say, he sometimes looks blue. You put a saturation, he is blue. You do a cardiopulmonary exam and it's totally normal. High on your list should be pulmonary AVMs or methemoglobinemia. Thank you so much for your time and excellent attendance and audience. I hope we made some difference in your life and practice to the better of your patients. Thank you.
روعة بروف، تسلم ايدك، جزاكم الله كل خير.
وإياكم آمين.
في كذا سؤال أقولهم حضرتك.
اتفضل.
أول سؤال، what's the cause of delayed onset of cyanosis in tetralogy of Fallot?
What's the cause of late onset?
Delayed onset of cyanosis في tetralogy of Fallot.
Late onset.
Late onset.
Yeah, late onset, it means they probably did not have significant RVOT stenosis. So they developed the stenosis with time, and it can happen. They can be born with minimal PS or sub-PS, and with time they develop it. They may have had severe stenosis, but they were born with that plus a PDA, and with time the PDA closed, so you see them more cyanotic with time. Or they may have developed collaterals that became stenotic with time. Another reason, which is extremely rare, you can see pulmonary hypertension sometime in tetralogy of Fallot patients, and it can make them cyanotic down the road. Another rare association is pulmonary hypoplasia. Okay, I hope I answered the question.
Differential diagnosis of cyanotic congenital heart disease from congenital methemoglobinemia.
You will find the first thing, normal cardiac exam. When you examine the patient, and examining the patient does not mean only auscultation. It means you do the saturation, the blood pressure, the pulses, the precordial exam, make sure the left ventricle is not active, the right ventricle is not active, no heave, no murmurs, normal S1, normal S2. Then you are more likely that you really have excluded a lot of the congenital heart disease. And then you have to look for causes that do not have a normal exam. What are the causes that can give you cyanosis with not a normal exam? These are methemoglobinemia or pulmonary venous abnormalities. AVM abnormalities. تفضل.
Can you explain DORV, please?
Double outlet right ventricle.
Double outlet right ventricle.
Yeah, so double outlet right ventricle is an example either of VSD or tetralogy or transposition, depending on the type of double outlet. If you have double outlet with normally related great arteries, no other association, then it is just a VSD, isn't it? So it will be a cyanotic heart disease with heart failure, because the VSD is usually large, and they will have good saturation, they will be heart failure type, and they will need VSD closure. If it is double outlet right ventricle with subpulmonary and pulmonary stenosis, they will act like exactly tetralogy of flow, and we call them double outlet right ventricle tetralogy type. If they are double outlet right ventricle with transposition or Tachycardia anomaly, there will be a typical transposition pathophysiology, but because the VSD is subpulmonic, they will have severe heart failure, and they can be very poor mixer with low SAT. Even though they have increased pulmonary blood flow from the VSD, they usually also do not mix and may need a septostomy. These are the differences between them. طبعا there are other varieties of double outlet right ventricle, but these are the main varieties. There are double outlet right ventricle is a huge diagnosis. It can be associated with mitral atresia, with coarcts, with hypoplasia of the right ventricle or the left ventricle. We're not going to go in all these severe forms. We talk about the three main types. It's either a VSD or a tetralogy or a transposition pathophysiology. And you can add to it sometimes a coarctation.
تمام. May you repeat RV sinusoids, please?
عيد السؤال.
RV sinusoids.
Yeah, what are RV sinusoids? طيب, what is RV sinusoids? If we imagine the right ventricle with pulmonary atresia and no VSD, what happens to the RV pressure? Is it going to be high or low? It's going to be high. So RV has trabeculations in it. And in utero, there are how the coronaries develop. They develop from these sinusoids intramural in the muscle. If there is high pressure because of obstruction, these enlarge and they communicate with the coronaries. So what is RV sinusoids? It's a communication between the coronary arteries and the RV cavity. If this communication is not obstructed, that means flow can come from the coronaries to the RV cavity and from the RV cavity to the coronaries. That's not a big problem. If they are obstructed, then the myocardium, the right ventricular myocardium, is dependent on the high pressure on the RV to feed the intramural coronaries of these or right ventricular muscle coronaries to feed the muscle, because no feeding comes from the aorta. So basically, what are RV sinusoids? They are communications between the coronary arteries and the RV cavity within the RV muscle wall or interventricular septum. اتفضل.
بروف المشكلة في السينوسويدز لو هي obstructed بس؟
Mainly, yes, mainly. طبعا non-obstructed they may steal, بس obstructed ones are the ones that you cannot relieve the obstruction. يعني لو عندك sinusoids وتبغى تفتح البulmonary valve، تفتحه ولا ما تفتحه؟
ايوه
ما
تمام.
تفتحه.
انا اقصد كده. تمام.
لو عندك sinusoids obstructed ما تفتحه، لانه البلد للكوروناريز جاي من الار في كافيتي للكوروناري.
تمام.
لو فتحته البلد حيروح للبulmonary artery ف it will infarct the right ventricle immediately.
طب لو sinusoids
لو كان
obstructed
ايوه النون obstructed الفلو يقدر يجي من الكوروناريز للرايت فنتركل ومن الرايت فنتركل للكوروناريز يقدر. لو فتحته the only thing that can happen is coronary steal، يعني يسحب blood من الكوروناريز بس ما يمنع البلد من الكوروناريز.
تمام.
نعم تفضل.
Thank you, Prof. In case of total anomaly, pulmonary venous drainage, obstructed type, infracardiac type, pulmonary placera is due to blood flow from the IVC.
It is due to obstructed flow down in the IVC. Yes, it is pulmonary venous edema. ايش اللي بيحصل؟ البلد يبغى يطلع من اللنج يروح للكومن فين هذا اللي نازل اسفل يبغى يدخل للاي في سي. That common vein is obstructed. So what happens? Pulmonary venous hypertension. Once pulmonary venous hypertension happens, you will have immediately increased leakage of fluid in the lung, and then pulmonary edema or plethora, and causing the severe deterioration of the patient. I hope I answered that.
تمام.
Now,
how can we diagnose AV malformation?
AV malformation of the lung can be diagnosed by many ways. One quick way by echocardiogram, you do the bubble test. You can shake or agitate saline and inject it in one of the right arms, and you will see that the bubbles will come to the left atrium very fast, within less than 4 seconds, which is too fast. يعني عشان يمر في البومري بلاد فلو سيركيليشن العادية ياخذ على الأقل 5 إلى 8 ثواني. لكن if it comes within 4 beats of the heart or less to the left atrium, then this is highly suspected. Other modalities of diagnosis, you can do CT heart or cardiac catheterization. Now,
تمام. When can we stop prostatin in duct-dependent cyanotic patient?
when do we start?
When can we stop prostatin?
You cannot stop prostatin in duct-dependent pulmonary circulation until you establish good alternative to the pulmonary circulation. Today, we can do PDA stenting. We put a stent in the ductus, ensuring continued pulmonary blood flow, or you can put a BT shunt, or if the pulmonary valve is perforatable, you can perforate, you can do that. So the answer, you never stop prostatin for ductal dependent circulation, whether left or right side, until you make sure you provided an alternative good circulation.
تمام بروف. Last question. In patient with single ventricle, if saturation is high, 95 to 96, do we need to do anything for him?
In single ventricle, saturation will never be 95, 96. It's almost يعني الهاي بالنسبة لهم is 94, 92. طبعا definitely you need to do something for them. لأنه as I said before, if you leave them, هذول عندهم unlimited pulmonary blood flow. They can develop pulmonary hypertension, Eisenmenger syndrome very early. That's why they need a pulmonary artery band early, within the first 3 months of life. So definitely مو عشان الساتوريشن كويس نتركهم، لا، هذه علامة بطالة، لأنه it means they will go to heart failure, pulmonary hypertension، وإحنا هدفنا دائما إنه ما يوصلوا لحاجة irreversible. تمام.
تمام بروف. ده كان آخر سؤال. جزاك الله خيرا. ربنا يكرم حضرتك، محاضرة روعة ما شاء الله كالعادة.
الحمد لله، الله يبارك ويعينكم وييسر الأمر للجميع يا رب، ونشوفكم دائما على خير، وإن شاء الله نقدم لكم أفضل وأفضل بحول الله عز وجل.
جزاكم الله كل خير. ربنا يبارك حضرتك.
السلام عليكم جميعا.
وعليكم السلام ورحمة الله وبركاته. سبحانك اللهم وبحمدك، أشهد أن لا إله إلا أنت، نستغفرك ونتوب إليك.
في أمان الله.